Today to have one of our own, and this is Rathi Pillai that will talk to us. When we started asking the question about having grand rounds and addressing cancer, your name quickly came to the forefront as somebody we ought to listen to and hear. And I understand that you're assistant professor in medical oncology, and that also you're a member of the discovery and developmental research program. And I think your interest is in biomarkers and how we can use those to treat cancer. So we'll listen with interest. Glad to have you with us. Thanks.
Thank you, Dr. Morris. I actually did all of my postgraduate training here at Emory, and it's an honor to be back in this auditorium. I remember sitting here 10 years ago as an intern, juggling pages on, cardiology service and trying to learn what I could about advances in medicine. And I never would have imagined that 10 years later I would be invited to actually give a talk here at Grand Rounds. I knew 10 years ago that I wanted to be a medical oncologist. My father is a medical oncologist, and I always wanted to follow in his footsteps, but I never really had a plan of where that was going to take me. And that's one thing that I just wanted to say to the trainees, that you just should keep an open mind. I stayed on at Emory for my fellowship training, and I was very fortunate to get to work with Suresh Ramalingam, who is our division chief and has been my mentor since fellowship. And that's how I got interested in becoming a thoracic oncologist. And it's incredible how much lung cancer therapy has changed even within my short career. Back in the 80s, when my father was in practice, they just started thinking that maybe chemotherapy was beneficial to lung cancer patients. And now chemotherapy has become a standard treatment in patients with metastatic disease. And what's even more interesting is that we have all these new treatments to offer patients, including immunotherapies or drugs that work by reactivating T-cell function against lung cancer cells. And immunotherapy has really revolutionized the way that we treat our lung cancer patients. And I now frequently have patients who are on immunotherapy and doing well with minimal side effects. And the patient that I always brag about when I'm speaking about immunotherapy across the country is a Navy veteran that was diagnosed with metastatic squamous cell lung cancer about 3.5 years ago. And he was started on an immunotherapy drug actually December 31st of 2015. And 2 years later, his disease remains stable. He's fully functional. He's actually more active than I am. He's done the Peachtree Road Race the last 2 4th of Julys, which is something that I have yet to try. So I hope that this next hour I will be able to share with you some of the advances specifically in immunotherapy, and then also the research that I've been involved with at Winship. We've been collaborating with a world-renowned immunologist who's right in our backyard, Rafi Ahmed, who actually was very integral in discovering the pathway that we have manipulated for cancer therapy. So my disclosures are that I have received research funding from Bristol Myers Squibb. I've served as a consultant for AstraZeneca. My biggest disclosure is that I am not an immunologist. I have learned a lot about immunology through working with Dr. Ahmed and his group, but I'm going to try and explain the science as best as I can, and I apologize for those of you who are more adept at immunology for the simplicity of my explanations. So the learning objectives of my talk, first of all, I wanted to briefly review the use of immune checkpoint inhibitors, which are the immunotherapy drugs that are now standard of care for patients with advanced stage or metastatic non-small cell lung cancer. And then I'm going to talk about 2 different publications that have come out of our collaboration with Dr. Ahmed's lab. The first is looking at the role of the co-stimulatory molecule CD28 in the ability of PD-1 and PD-L1 inhibitors to be able to rescue exhausted T cells, both in chronic viral infections and in cancer models. And then finally, I'm going to talk about some of the work I've been involved in looking at using the peripheral blood as a source of potential biomarkers for patients who receive these types of treatments. So the mandated first slide of any lung cancer talk is talking about the incidence of lung cancer. And over 230,000 cases are expected to be diagnosed in the year of 2018. And unfortunately, most patients who are diagnosed with lung cancer are diagnosed when they have advanced stage disease, when surgery is no longer an option, and really the main treatment is systemic therapy, which up until a couple of years ago was really just chemotherapy. And as you can see from the figure, for both men and women, lung cancer remains the number one cause of cancer-related death. So clearly there is a lot of room for improvement in the thoracic oncology sphere. Hopefully some of that will come from adoption of lung cancer screening and finding patients with earlier stages of curable disease, and then also with finding better and more effective systemic therapies. So this is a case that we actually saw back towards the end of my fellowship here at Emory. This was a patient that we met in our lung cancer clinic. He was a dedicated smoker and had been diagnosed with metastatic squamous cell lung cancer. And he came to Emory looking for treatment options because his oncologist had treated him with multiple different types of chemotherapy, and the chemotherapy wasn't working anymore. At that time, we actually had a trial open with one of the earliest immune-activating treatments, a drug called nivolumab, which targets the programmed DEath1 receptor on T cells. And so this patient was interested and agreed to enroll in the trial, even though this meant that he would have to drive 3 hours to come to Emory for his treatment every 2 weeks. And on the left side, you will see his baseline CT scan, which shows a pretty big tumor right next to the hilum and the mediastinum. And the patient got one infusion of the nivolumab and subsequently developed very severe shortness of breath. He didn't have to get admitted or hospitalized, but it scared him. And it scared him enough that he decided he didn't want to try this experimental treatment anymore. So he withdrew from the clinical trial and decided to follow with his local oncologist. And we told the local oncologist, please just get a scan in a few months and see how things are looking. And on the first scan, the patient's tumor was almost completely gone. And 1 year later, the tumor was still undetectable. And his scans actually remained like this for a total of 2 years before his cancer recurred. And then he had to go back on treatment with his local oncologist. This is a very atypical, outstanding response to immunotherapy. This is by means not what we typically see in our clinic. But this type of extraordinary response obviously gets people excited and gets people like me interested in what makes this patient and his cancer so sensitive to this medicine, and how can we figure that out, and what can we do to really utilize these medications in the most effective manner. So by way of a simple immunology background, I'm going to start by talking about T cell signaling. And as you may or may not remember from medical school immunology class, T cell signaling actually requires two different signals. The first signal to activate a T cell is actually binding of the T cell receptor on the T cell to an antigen-presenting cell which has an MHC class receptor and antigen. And when you have that first binding, that's not enough to actually result in T cell activation. You actually need a second co-stimulatory signal in order to really get the T cell to be activated and do its thing. And there are different co-stimulatory molecules that are found on the surface of T cells. In this figure, we see CD28, which is a very prominent co-stimulatory molecule that engages its two receptors B7-1 and 2 on antigen-presenting cells. And when you have both the T cell receptor and the co-stimulatory molecule, in this case CD28, activated and engaged by their ligands, that actually is sufficient to be able to turn on T cells and results in T cell proliferation. We now know that there are many different receptors on T cells besides just the T cell receptor. And there are actually many different co-stimulatory molecules such as CD28, which serve as activating receptors of the T cell's function. And some of these are listed here. OX40 and GITR are among them. And conversely, there are actually many inhibitory receptors that are also on the surface of T cells. And the purpose of the inhibitory receptors is to modulate the T cell activation, because you don't want to have a T cell that just stays on all the time. That's when we end up with bad things like autoimmune diseases. And some of the inhibitory receptors, or checkpoint receptors, is another terminology for these receptors, are CTLA4 and PD1. And CTLA4 and PD1 are two inhibitory receptors that have been targets of oncology drug development and have actually resulted in several medications that are FDA approved for the treatment of many different types of cancer. These drugs were initially used in melanoma, but now they have spread to many different types of tumors, including lung cancer. And all of these different activating receptors and inhibitory receptors are now very much the focus of new drug development for oncology. And there are many blocking antibodies that are being developed against the inhibitory receptors, and conversely, many agonistic antibodies that are being developed against the activating receptors. All of this is trying to reactivate a T cell to start attacking the tumor antigens. So I will be focusing on the programmed cell death 1, or PD1, immune checkpoint pathway, because that is where we have several different medications in lung cancer that have been approved that target this pathway. So programmed cell death 1, or PD1, is actually a receptor that is expressed on the surface of antigen-experienced T cells. And the role of the PD1 pathway is actually to try and limit the activation of T cells at the time of an inflammatory response. So this protects normal tissues from collateral destruction. And what happens is that once a T cell is activated by the two signals of the TCR and the co-stimulatory molecule being activated, the T cell can then traffic into the peripheral tissues to start attacking its specific antigen. And in the peripheral tissue, as the T cell is experienced with antigen, it actually starts expressing the PD1 receptor on its cell surface. And as this is happening, the inflammatory milieu around the T cell contains a lot of cytokines such as interferon gamma. And interferon gamma can actually induce expression of the ligands of the programmed death 1 receptor. And there are two different ligands, PDL1 and PDL2, that can be expressed on different types of antigen-presenting cells and other cell types, including tumors. And so when the PD1 receptor is present and the ligands are present, there is a binding reaction, and this essentially starts an inhibitory signaling cascade within the T cell that shuts off the T cell's function. And again, this is present to limit autoimmune destruction of tissues. Unfortunately, sometimes this system can be too effective. And what Dr. Ahmed's lab actually found is that in the setting of chronic viral infections, where you have T cells that are chronically being exposed to viral antigens such as hepatitis B, or in their lab, they have used a model of a mouse infection called LCMV, or lymphocytic choriomeningitis virus infection. What can happen is that the CD8 T cells can actually become exhausted or anergic, and they quit being able to function. And cancers can also take advantage of this inhibitory pathway. And there are many different types of cancer that can actually overexpress this PDL1 ligand on the tumor surface. And then what happens is that when a T cell encounters the tumor cell, essentially the tumor cell is wearing camouflage as far as the T cell's function is concerned, and the T cell is not able to have any cytotoxic effect against the tumor cells. So with understanding of this pathway, there have been many different monoclonal antibody drugs that have been developed that actually interfere with the binding of the ligands to the PD1 receptor. And there are several monoclonal antibodies that are specific to the PD-1 receptor itself. And then there are also monoclonal antibodies against the ligand PD-L1. And we do have various drugs of both classes that have been approved for treatment of patients with lung cancer and now many other tumor types, Hodgkin's lymphoma, bladder cancers, melanoma. And essentially these drugs are being tested in every single tumor type because they can be very effective. So PD-L1, the ligand that can be overexpressed on different lung tumors, is something that has been investigated as a potential biomarker to identify patients that would be likely to benefit from a treatment that targets this pathway. And PD-L1 expression is generally studied by looking at protein expression using immunohistochemistry assays. And there are actually a lot of different types of PD-L1 antibodies that are available. And there are also different interpretations of what constitutes a positive result or positive PD-L1 expression on a tumor cell. Some of the variances in positive PD-L1 include whether the staining for PD-L1 is just restricted on the tumor cells, as in this top figure. There are a few antibodies that actually also look at PD-L1 expression on tumor-infiltrating immune cells down below. And so that's one source of variability. There are also many different cutoffs of what constitutes positive. There are some antibodies where a very low expression of PD-L1, as you can see in this middle panel, where there are a few dark brown cells here, would constitute a positive result. And then on the right panel, you see very strong staining of PD-L1, and some of the assays would want this kind of degree of staining to be called positive. So there is a lot of variability in the definition of what PD-L1 positivity is, just in the test itself. And then secondly, there is also a lot of variability within just checking for PD-L1 in a patient's tumor. In a lot of my patients who have metastatic lung cancer, the patients may have different sites of disease. They may have pulmonary nodules and liver nodules, and there can be some variability in checking the status of PD-L1 expression based on what tumor I sample. There could also be variability based on the sampling of the tumor itself. You could imagine that there could be a region of immune cell infiltration in one side of a tumor, but when I send the patient for a CT-guided liver biopsy, this side of the tumor is sampled, and so I don't get to see that there was actually some immune activation and part of the tumor. And so I miss that patient actually did have PD-L1 expression. The other problem with checking for PD-L1 expression is that you do have to get a sample of the patient's tumor in order to test for this. There are some biomarkers for targeted therapies where we're able to check samples of peripheral blood and find circulating tumor DNA to look for activating mutations, but we cannot, as of yet, detect PD-L1 expression on anything other than a tumor sample. So that also makes it a little bit more difficult of a test. And there have been questions on whether you have to get a fresh tumor sample at the time that you're starting the patient on a PD-L1 or PD-L1 inhibitor, or if you could use an archival tumor sample. Say you had a patient who originally had a stage 1 lung cancer that was resected, and 2 years later they developed metastatic disease with the same tumor histology. Is it enough that the tumor resection specimen had PD-L1 2 years ago? Is that indicative of immune activation within the lung cancer that you're treating now? We don't fully know that. So PD-L1, it has been one of the first biomarkers that have been used to try and find patients that are going to benefit from these immune checkpoint inhibitors, but there have been a lot of problems with it. This table summarizes the main PD-L1 antibody assays that are currently available. On the top, you'll see 4 different drugs that are used in lung cancer. The 2 left drugs are PD-1 inhibitors, and the 2 right columns indicate 2 PD-L1 inhibitors. And what you'll notice is every single one of these drugs actually has a different antibody clone that is being used to look for PD-L1 expression. Most of the antibodies are looking at expression solely on tumor cells, but the Ventana assay for atezolizumab actually also looks at the immune cell expression. And you can see on the bottom row that there are different definitions of what constitutes a positive result. So this has made it somewhat confusing for especially a clinician to know what type of PD-L1 test to order when they have a newly diagnosed patient with lung cancer. So I'm going to go into a few of the clinical trials that have shown that PD-1 inhibition is a successful target of lung cancer therapy. And the first arena that PD-1 and PD-L1 inhibitors were tested in was in the salvage setting. So when you have a patient who has metastatic lung cancer, the standard original therapy is usually combination chemotherapy with platinum doublet chemotherapy, usually carboplatin or cisplatin combined with a second drug. And a patient can do well on that, and subsequently, if they develop disease progression, we go to a salvage chemotherapy, and that salvage chemotherapy has been docetaxel since the 1990s. We haven't been able to find anything that works better than docetaxel in the salvage setting until we had these immunotherapy drugs. So all of these drugs were initially tested compared to docetaxel to determine if they were any better than the standard salvage therapy. And nivolumab is depicted here. Nivolumab is a PD-1 inhibitor, and it was compared to docetaxel in both squamous non-small cell lung cancer and non-squamous non-small cell lung cancer. And nivolumab is in blue, and you can see that nivolumab increases the median overall survival in both squamous and non-squamous histologies, and the improvement in survival is about 3 months in both situations. PD-L1 expression was looked at in both of these trials, and interestingly, PD-L1 expression did correlate with an improved likelihood of having a response to nivolumab. The overall response rate seen with nivolumab and any of these drugs in the salvage setting is about 20% of patients will actually achieve a partial response by RECIST. And if you had a higher level of PD-L1 expression in squamous histology patients, you had a higher response rate. That correlation was not seen in the non-squamous population. Irregardless of that, whether or not you had PD-L1 expression, the patient outcomes in terms of response rate, survival, and toxicity were better than docetaxel, even in those patients who were PD-L1 negative. And so based on that, the FDA approved nivolumab in both squamous and non-squamous histologies and did not mandate that we need to check a PD-L1 on a tumor specimen before starting treatment. Conversely, pembrolizumab is another PD-1 receptor antagonist that has been tested in non-small cell lung cancer. And this drug was very highly correlated with PD-L1 expression in terms of determining efficacy with pembrolizumab. And these curves on the left show a single-arm trial with pembrolizumab looking at various cutoffs of PD-L1 expression. Green is negative, yellow is 1 to 49%, and then black is the highest level of PD-L1 expression, 50% or higher. And you can see that the very high PD-L1 expressors had the most significant improvement in survival. And so this is an important point to remember. Again, when pembrolizumab was compared to the standard of docetaxel, you can see that both doses of pembrolizumab resulted in improved overall survival. The FDA approved pembrolizumab on the basis of this data and has mandated that we check a PD-L1 on patients in order to prescribe pembrolizumab. And then finally, atezolizumab is a PD-L1 antagonist, and it was also studied against our standard salvage docetaxel and metastatic disease. Patients were randomized to the two different drugs, and again, looking at overall survival, you can see that the atezolizumab in red resulted in an improved overall survival. The hazard ratio was 0.73. When they looked at PD-L1 expression with atezolizumab, they again found that the hazard ratio for survival did increase slightly in those patients who had the highest levels of PD-L1 expression, but still patients who did not have PD-L1 expression had an improved survival compared to those who were treated with docetaxel. So PD-L1 expression is not something that's used to select patients to treat with atezolizumab. And then finally, more recently, we have found that immunotherapy can be effective as the first treatment in a patient with metastatic lung cancer. I had mentioned that we usually were treating patients with platinum doublet chemotherapy when they presented with metastatic disease. And this study, the KEYNOTE-024, looked at the standard of platinum doublet chemotherapy compared to using the immunotherapy pembrolizumab in patients who had stage 4 lung cancer and who had high expression of PD-L1, 50% or higher, based on the previous data that showed that those patients were the most likely to benefit from pembrolizumab. Patients on this study could continue the pembrolizumab until they developed disease progression or for up to 2 years. And the chemotherapy was continued for up to 6 cycles, which is our usual standard. And this study did allow for crossover, so those patients who were randomized to chemotherapy were subsequently allowed to cross over to pembrolizumab when they developed disease progression. The primary endpoint of the study was progression-free survival, and this study was actually published in the New England Journal of Medicine in 2016, and it showed that there was a 50% reduction in the hazard of progression or death with the use of pembrolizumab in the first-line setting. The median PFS for pembrolizumab was 10.3 months compared to 6 months with chemotherapy. At the time of the publication, the overall survival data was not mature, but there was a promising separation of the curves for overall survival. And recently at our International Lung Cancer Conference in October, they did update the survival from this study, and the patients who received upfront pembrolizumab had a median overall survival of 30.7 months versus chemotherapy where we only had a survival of 14.2 months, which is quite remarkable that a patient with metastatic lung cancer could reasonably see years of survival on their first treatment. So this has completely revolutionized the way that we approach treatment of our metastatic patients. And now anybody who has a newly diagnosed metastatic non-small cell lung cancer, we routinely do check for PD-L1 status. And in those patients who have 50% or higher expression of PD-L1, we preferentially give them upfront immunotherapy rather than chemotherapy. So this table summarizes all of that data that I just reviewed. There are a couple of other PD-L1 inhibitors that are currently in clinical trial. Nivolumab and pembrolizumab have been approved in the salvage setting, as well as atezolizumab, which is our sole PD-L1 inhibitor. And then pembrolizumab does have an approval in newly diagnosed metastatic lung cancer in those patients who have high expression of PD-L1. So shifting gears, I'm going to start talking about some of the work that we've been doing with Rafi Ahmed's lab. And the majority of this work has been done by a brilliant postdoc in Dr. Ahmed's lab, whose name is Alice Kamphorst. And Alice was interested in trying to figure out what is required to be able to rescue an exhausted T cell. And as we had reviewed earlier, we know that the blockade of, the activation of the T cell requires both the T cell receptor binding to APC as well as binding of the co-stimulatory molecule CD28 to its ligands B7-1 and B7-2. What is not known is whether the interaction between PD-1 and its ligands would require also signaling from the CD28 pathway in order to be able to rescue an exhausted T cell. And that's exactly what Alice was trying to figure out with the following experiments. So I had mentioned that Dr. Ahmed's lab has used a mouse model of chronic viral infection, and this is a model which uses the LCMV virus, lymphocytic choriomeningitis virus. And it's been known that when you have an LCMV chronically infected mouse and you treat it with either a PD-L1 inhibitor or a PD-1 inhibitor, you can actually see rescue of CD8 T cells because you're blocking that inhibitory signaling between PD-1 and its ligands. And what Alice did was take that same experimental model and also add the variable of an antibody against the ligands to the CD28 molecule. So she used antibodies against B7-1 and B7-2, and then looked at the T cell profile in these mice after the treatments. GP33 and GP276 are both tetramers that are specific LCMV viral markers of viral T cells. And what you can see in these flow cytometry plots is when you have an untreated mouse, there is a low expression of PD-1 positive T cells, but when you give the mouse a PD-L1 antibody, it increases the number of PD-1 positive T cells. However, when you co-treat the mouse with both a PD-L1 antibody and a B7 antibody, it abrogates the ability of the PD-L1 to rescue those PD-1 positive T cells. And these graphs here depict that in both the spleen and in the lung. Again, you see an increase in viral-specific T cells with PD-L1 inhibition, and that increase is lost when you treat with a B7 or B7-2 antibody. So that suggests that it's necessary to have signaling with CD28 and B7 in order for these PD-1 and PD-L1 drugs to be able to rescue the T cells. In the bottom flow cytometry plot, what you can see here is just, again, increase in CD8 positive proliferating T cells in response to treatment with a PD-L1 antibody, and that's lost when you block the CD28 and B7 pathway. Ki67, in case you're not aware of this, it's a marker of cell proliferation and cycling cells, and that's a very commonly used marker that we'll be looking at in a lot of these experiments. So still looking at the LCMV model, Alice also looked at the production of interferon gamma. Interferon gamma is a marker of effector function of cytotoxic T cells. And when you treat these LCMV mice with PD-L1 inhibition, it results in a very nice increase of interferon gamma release from the T cells. But again, when you block CD28 with a B7 antibody, you lose that increase in the interferon expression, similarly to the mice that didn't have any treatment. On the bottom panel, you can see that increase in interferon gamma production depicted on flow cytometry plots, again, increased with PD-L1 inhibition, and that increase is lost when you block the B7-2 CD28 pathway. On the right, there are two graphs here, again, that are looking at another marker of effector function of cytotoxic T cells, the expression of granzyme B. And once again, similarly to interferon gamma, we see a very nice increase in the expression of granzyme B in the mice that receive a PD-L1 inhibitor, but that increase is lost when we block CD28 signaling with the B7 antibody. And then down below, this is a plaque-forming assay looking at viral load, essentially. And the mice that receive PD-L1 inhibition have a decrease in the viral load as depicted on the plaque-forming assay, and that reduction in viral load is lost when we introduce a B7 antibody to the treatment. So the summary of these first two slides of experiments suggest that B7 co-stimulation is really required in order to have effective PD-1 therapy in LCMV chronically infected mice. The next set of experiments was looking at whether the loss of CD28 after a T cell is already exhausted by antigen stimulation would also impair rescue by PD-1 blockade. And these experiments used a Cree-Lox model where tamoxifen was used to delete CD28 expression. And you can see that there's a really nice decrease in CD28 positive T cells on the flow cytometry plot with the use of tamoxifen. At baseline, about half of the cells are CD28 positive and half are CD28 negative. And in this model, what Alice did is she looked at a wild-type mouse and then the Cree-Lox mouse, and infected these different mice with the chronic viral infection. And after that infection had set in for about 35 days, introduced tamoxifen. And those mice that had the Cree locus had a deletion of the CD28 expression in about half of their cells. And after 5 days of treatment with tamoxifen, then the PD-L1 inhibitor was introduced. And below you can see the results of the experiment. So in the P14 wild-type mice, all of the cells express CD28, and when a PD-L1 inhibitor was used for treatment, all of the T cells, well, high number of T cells, were able to be rescued and were able to proliferate in response to the PD-L1 inhibitor. In the next panel, you can see the different populations of CD28 positive and CD28 negative T cells in the Cree mouse. And the mice that had CD28 expression were again able to have a similar increase in T cell proliferation with treatment with a PD-L1 inhibitor. But in those mice that lacked CD28 expression, that increased proliferation was completely lost. So this shows that CD28 is necessary even in an already established viral infection. You need to have expression of CD28 in order to be rescued by a PD-L1 or PD-1 inhibitor. And again, in the flow cytometry diagrams here, you can see on the top right panel, these are the CD28 expressing T cells that have a nice increase from untreated to treatment with the PD-L1 inhibitor, but conversely, those CD28 negative T cells have no increase in proliferation. So again, CD28 is necessary for T cell rescue by PD-1 and PD-L1 inhibitors. Alice also looked at this in a mouse model of colon cancer to see if CD28 signaling was needed in order for cancer cells to be rescued by PD-1 inhibitors. And these top graphs are looking at tumor volumes in these mice with colon cancer. On the left, you see the untreated mice who have very nice growth of the colon cancers. When we treat these mice with a PD-L1 inhibitor, 8 out of 9 mice have a very nice abrogation of the tumor growth. However, when we treat the mice with either just a B7 inhibitor or the combination of PD-L1 with a B7 antibody, again, the tumors grow without inhibition. So this is suggesting, again, that CD28 signaling is necessary for the colon cancers to be able to respond to a PD-L1 inhibitor. And down below is a graph summarizing those results in multiple experiments. And then finally, this is a survival curve of the mice in this experiment that showed that those mice who had the best reduction in tumor growth, who had just treatment with the PD-L1 inhibitor, have the longest survival, and that survival advantage is lost when we introduce a B7 antibody to the mix. So again, this confirms the necessary role of CD28 signaling in the rescue of exhausted T cells in a mouse model of colon cancer. So the conclusions from these mouse models, one is that proliferation of exhausted CD8 T cells following blockade of the PD-1 pathway is dependent on CD28 signaling. And then secondly, our findings imply that the optimal rescue of both exhausted T cells in chronic viral infections and in cancers will require antigen presentation by B7 expressing cells. And then finally, from this part of our story, Alice looked at some human lung cancer cells to determine if CD28 expression varies within tumor-infiltrating lymphocytes. So she actually obtained some surgical resection specimens from some of her cardiothoracic colleagues who had some early-stage lung cancer patients. And she looked at tumor-infiltrating lymphocytes in both the cancer and the adjacent normal tissue. And what she found is that within the tumor-infiltrating lymphocytes, or TILs, there is variability in CD28 expression. You can see about 41% of the cells do express CD28, but almost half of them do not have CD28 expression. And this is summarized here in this graph looking at CD28 positive CD8 T cells, and you can see that CD28 ranges anywhere from 20 to 90% of the TILs in a human lung tumor. So this actually is really interesting because it may explain why there is variability in some of our patients' ability to respond to a PD-1 or a PD-L1 inhibitor. These CD28 T cells would likely not be able to respond very well or be rescued by a PD-1 directed therapy. And then finally, Alice also looked at some of the peripheral blood specimens or samples from patients in our clinic who were receiving immunotherapy with PD-1 or PD-L1 inhibitors for metastatic lung cancer. And what she did is she got a baseline blood sample before the patient received the immunotherapy, and then 2 to 3 weeks later when they came back in for their next treatment, she got a post-treatment blood sample. And what this flow diagram here depicts is that a lot of the patients had an increase in their PD-1 positive T cell population from baseline to post-treatment, and you can see that in 2 of the patients. In looking at other markers of effector T cell function, which we know include expression of the molecules HLA-DR and CD38, we again see that the majority of these proliferating T cells that are seen in the peripheral blood express both HLA-DR and CD38, suggesting that these are effector T cells that are coming out into the peripheral blood with treatment with PD-1 or PD-L1 inhibitors. And the majority of the Ki67 PD-1 positive CD8 T cells that we do see in the peripheral blood seem to have this effector phenotype. And then finally, when we look at just the summary of all the post-treatment blood samples in this small cohort of patients in the peripheral blood, all of those T cells that were proliferating and detected in the peripheral blood actually did express CD28. So again, this seems to suggest that CD28 is necessary for T cells to be able to proliferate in response to a PD-1 inhibitor. So the conclusions from the lung cancer patient samples, one is that many of the TILs that we see in lung tumors do not express CD28 and therefore may not be very responsible to blockade with PD-1 inhibitors. And also that the CD8 T cells that respond to PD-1 targeted therapy tend to have expression of CD28, which goes along with our findings in the mouse model. So to wrap things up, I'm going to talk a little bit about some of the specific biomarker work that we've been doing with Dr. Ahmed's lab. We actually have an IRB-approved protocol that we've had open at Winship since I started on faculty 4.5 years ago. And the purpose of this protocol is basically allowing us to collect blood samples from any patient who gets immunotherapy at Winship for any indication. And what we've done with this protocol is we collect a baseline blood sample before the patient is exposed to any immunotherapy. And then after the patient returns for treatment, either every 2 to 3 weeks, depending on the type of immunotherapy the patient is on, we collect post-treatment blood samples. And we have gotten post-treatment samples after the first treatment, the second treatment, and then a fourth sample ranging anywhere from after the third or sixth treatment. And we've used these blood samples to ask the question if we can actually detect changes in the peripheral blood in patients who get treated with immunotherapy. This table summarizes the patient characteristics of our initial 29 patients that we've studied to date. The median age of the sample is 66, which is around what you would expect in an average metastatic lung cancer population. 86% of the patients are former or current smokers. All of the patients had metastatic disease at the time of being on study, although about 65% of them actually had metastatic disease at initial diagnosis. And 45% of the patients had only one prior line of therapy. 86% of the patients had prior radiation. And then looking at the different immunotherapies that were included in this study, 73% of the patients received nivolumab, and a few received pembrolizumab and atezolizumab. And this just reflects both our clinical trial portfolio at Winship and also the timing of FDA approval of these drugs. Nivolumab was the very first immunotherapy to be approved, and so patients have had the opportunity to be treated with nivolumab longer than with the other two agents. And then in looking at best disease response, 41% of the patients achieved a partial response, which is a little bit higher than we would typically expect with immunotherapy. We traditionally see about 20 to 25% of patients who achieve a partial response. So the first question we asked was whether T cells responding to treatment can be detected in the peripheral blood. So we analyzed CD8 T cells and then CD4 T cells, and we differentiated between conventional CD4 T cells and Tregs by the expression of FOXP3, which is only seen in Tregs. And in the pretreatment patient sample, you can see that the highest proportion of cells were Tregs, and that's actually similar to what you would see in a healthy person. In the post-treatment samples, you can see that there was a nice increase in the CD8 T cell population, but the CD4 and Treg population stayed pretty stable. So we then looked at the average highest full change in proliferating T cells as marked by Ki67, and found that the highest proliferation was actually seen in the CD8 T cell population, whereas CD4 and Tregs stayed pretty stable. And this rectangle is drawn around the 20 or so patients that had what we called a detectable CD8 T cell response, which we defined as at least a 1.5-fold increase in CD8 T cells. And these 20 patients are the focus of our subsequent analysis and characterization of the T cell population. So what you can see in this figure, on panel A, what we're looking at is the expression of PD-1 in the proliferating T cells. And there's a lot of variability, but a lot of the proliferating T cells are PD-1 positive. There are circles around those 3 patients that had a mixed population of proliferating CD8 T cells, and then there were 2 patients who actually had PD-1 negative proliferating CD8 T cells. And panel B shows flow cytometry specimens from 2 patients who had a nice increase in the PD-1 positive T cell population with treatment with PD-1 or PD-L1 inhibitor. Conversely, in plot C, you can see those 2 patients that had actually proliferation from baseline to post-treatment of the PD-1 negative population. And this was, again, the minority of patients that we saw proliferation in PD-1 negative cells. Again, looking at markers of effector phenotype of the T cells, those include decreased expression of BCL2, which is an anti-apoptotic protein, and then expression of HLA-DR and CD38. You can see that most of the proliferating PD-1 positive CD8 T cells actually had low expression of BCL2, and this graph is actually looking at the percent of patients who had low BCL2 expression, so that was almost 100%. It's a little bit confusing the way that was depicted. And then looking at other markers of effector T cell function, there's high expression of HLA-DR and high expression of CD38 seen in these proliferating T cells. And again, most of the proliferating T cells had both of these markers. Other markers of effector T cells are low expression of CCR7, as seen here, as well as CD45RA. And the majority of the proliferating PD-1 positive T cells had those 2 markers of effector function. And then finally, increased granzyme B is a marker of cytotoxic potential of T cells. And similarly to what we saw in the mouse experiments, these proliferating T cells seem to have higher expression of granzyme B. So taken in summary, it appears that not only can we detect proliferating CD8 T cells in the peripheral blood of lung cancer patients who receive immune checkpoint inhibitor therapy, but those T cells seem to have effector phenotype. We also looked at the presence of co-stimulatory molecules on these proliferating T cells because from our mouse work, we knew that CD28 seems to be an important molecule in order for a T cell to be rescued by these immune checkpoint inhibitors. And again, we see in the proliferating PD-1 positive T cells that there's high expression of both CD28 and CD27, which is another co-stimulatory molecule, and that's depicted in the flow cytometry plots here. And ICOS is an inducible coenzyme that is also expressed to variable degree in the proliferating PD-1 positive T cell population. And what we found is those T cells that are both PD-1 positive and proliferating have the highest expression of ICOS compared to those T cells that are PD-1 negative or those that are not proliferating. So not only are the proliferating T cells expressing an effector phenotype, they also express many co-stimulatory molecules. And we were interested to see that those T cells that are proliferating, again depicted by Ki67 positivity, compared to the non-proliferating T cells, tend to have higher expression of the PD-1 receptor. And so we also looked at another co-inhibitory molecule called CTLA4, and once again found that the proliferating PD-1 positive T cells had the highest levels of the CTLA4 inhibitory receptor on their surface compared to those T cells that were PD-1 negative and the non-proliferating T cells. And basically this is probably just showing that T cell receptors are being engaged because not only for PD-1 but also for CTLA4, both of these receptors are upregulated in those cells that are having active T cell signaling. And down below you can see a plot of the variability of the CTLA4 expression on these proliferating T cells. Shifting back into more clinical endpoints, going back to the 29 patients in our cohort of lung cancer patients treated with immunotherapy, this is a waterfall plot looking at best disease response in those patients who received immunotherapy. And in oncology, what we define as a response or partial response is depicted here by the dotted line, with at least a 30% reduction in tumor burden. And conversely, patients who have at least a 20% increase in tumor burden are considered to have disease progression. Anybody in between is considered stable disease. So we had 12 patients who achieved partial response, and we had a good number of progressors as well. And you can see that those patients who had a partial response had the best survival, and nearly all of them were still alive or actually all of them were alive at 1 year after starting on the study, compared to the patients who had disease progression who had a much inferior survival outcome. So we wanted to see if we could correlate these clinical responses that we measure on radiographs to the immunologic responses that we can see in the peripheral blood. And that's what this figure is depicting. In the top panel A, this is what's called a spider plot, and it's looking at the changes in tumor burden for each individual patient over time. And so you can see that there are a good number of the partial responders who have a nice reduction in their tumor burden within 2 months, and it can stay suppressed with continued immune therapy. In panel B, we're looking at the immunologic response of each individual patient. So the plots are showing baseline PD-1 positive Ki67 T cells and what happens to that population at each individual time point. And we found that most of the patients that we had in this cohort of patients actually had an early proliferative signal with that specific CD8 T cell population. So 80% of the patients actually had a nice increase in their CD8 Ki67 positive, PD-1 positive T cells by the time of their first time point of 2 weeks. And the majority of the patients who had a partial response were actually in that particular patient population. There were 2 patients who had early proliferation of their T cells that were also, unfortunately, had progressive disease as their best disease response. And interestingly, these 2 patients in that group actually had proliferation of PD-1 negative T cells. So perhaps the reason that they didn't have a benefit from the immune checkpoint inhibitor was because they were proliferating ineffective PD-1 negative T cells. There was a smaller group of patients that either did not have any immunologic response or any significant proliferation of their CD8 PD-1 positive T cells, or that response was delayed past the 2-week mark. And what we did is we looked at correlating early response versus absent or delayed PD-1 CD8 positive T cell response. And what we found is that 57% of the partial responders actually had an early PD-1 positive CD8 T cell response, compared to only about 21.5% of the patients who had disease progression. When you look at the patients who didn't have a T cell response or who had a delayed PD-1 CD8 positive T cell response, the majority of the patients in that group actually had disease progression. A little over half of them had disease progression, and only 15% of those patients who had a delayed or absent T cell response actually had radiographic response seen on their scans. So the conclusion from our small study of patients with lung cancer is that proliferating T cells, which are likely tumor-specific in response to PD-1 and PD-L1 inhibitors, can be detected and monitored in the peripheral blood. The proliferating PD-1 CD8 T cells that we can identify have an effector phenotype with low BCL2 and high HLA-DR and CD38 expression, and they express both co-stimulatory molecules such as CD28 and inhibitory receptors like PD-1 and CTLA4. And finally, it appears that we can correlate the PD-1 positive CD8 T cell response with clinical response as measured by RECIST criteria. So future directions of our work with Dr. Ahmed's lab, we are interested in further studying the role of CD28 in lung cancer patients, and we're looking at trying to develop a neoadjuvant immunotherapy protocol where we give immune therapy to a surgically resectable lung cancer patient and then try and get samples at the time of surgery from both the tumor and the lymph nodes in order to look at CD28 expression and see how that may factor in the patient's pathologic response to immunotherapy. We already are working on expanding our cohort of peripheral blood analysis at the Cancer Center. We have been collecting more patients with lung cancer, and as these drugs have been expanded in other tumor types, we are using more of these drugs as standard therapy in renal cell carcinoma, bladder cancers, and other tumor types. And so we are also trying to collect blood from those patients and see if we see similar findings in different tumor types. And then finally, we have an investigator-initiated protocol at Winship where we are treating patients with nivolumab and getting pretreatment tumor biopsies as well as blood samples on all of these patients. I'm trying to further characterize the T cells and see if there are similarities in the blood and the tumor T cell populations. So I thank you for your attention. I just want to acknowledge all of the wonderful, brilliant folks in Rafi Ahmed's lab, mainly Alice Camphorst, who was really integral to all of the science that you saw here. Rafi Ahmed has been just a very generous and kind collaborator and mentor. And then Suresh Ramalingam at the Cancer Center has been my mentor since fellowship, and Tofika Wanakoko and Gabe Sika are both an oncologist and a pathologist that we work really closely with at the Cancer Center. Thank you. I'd be happy to take any questions.
A great presentation. Unfortunately, our time is quite limited, and we much appreciate an incredibly exciting field in which Emory, and as your work indicated, is leading the space. I'll take any burning one question in our time. Yes.
What is the proportion of, say, metastatic lung cancer patients who have PD-L1 positive? I mean, that's now the standard of care, right, to go do immunotherapy up front. But you have to have the hurdle of PD-L1 positive. What proportion pass that hurdle?
That's a great question for newly diagnosed metastatic patients in the KEYNOTE-024 study, where the cutoff was 50% or higher. There were about 1/3 of patients who met that cutoff. And clinically in my practice, that's pretty similar to what I'm seeing in my patients.
Thank you very much.
You.